India, which is the Regional Prospective Observational Study on Tuberculosis. We are also like to welcome Dr. Ramya I. Dr. Ramya is currently the professor and head of our Medicine Unit 5 at CMC Vellore. She has about 150 publications in different peer-reviewed journals, and she has also undergone training in medical anthropology in the University College of London. Ma'am's areas of interest include medical anthropology, medical education, health, and vaccinology. Thank you, sir and ma'am. I'd like to introduce our first speaker for this session. Dr. Barney Isaac will speak on updates in interstitial lung disease, pulmonary arterial hypertension, and lung transplant. Sir is a professor in the Department of Pulmonary Medicine at CMC Vellore. He has 16 years of expertise in respiratory medicine and has awarded the third prize at NAPCON 2008 for research in IPF. His areas of interest include IPF, respiratory function testing, allergy and asthma, and pandemic response. Today's topic for Sir is updates on ILD, PAH, and lung transplant. On to you, sir. Thank you.
I thank the organizers from the Department of Medicine for giving me this opportunity to share on the updates in three broad topics: interstitial lung disease, pulmonary hypertension, and lung transplant. So, as I started preparing for this, I realized that I decided to bite more than what I can finish in 40 minutes. So I've tried to allot time like this. First 15 minutes, we will look at ILD, next 10 minutes, pulmonary hypertension, and 15 minutes on lung transplant. I have a lot of slides. I need to run past quickly some, but I'll focus on where attention is needed to get past some important information to all of you. So each topic I will briefly overview for those of us who are a bit beginners in internal medicine. I'll focus on certain areas of each of these topics and also provide recent updates as we go along. So interstitial lung disease is also called diffuse parenchymal lung disease because it not only involves the interstitium, and this classification brings together the multiple classifications which have evolved over years in ILD. So broadly, you can you can classify ILDs into that which have etiology, which are on the right three downstream arrows, and those which do not have any etiology when they are called idiopathic interstitial pneumonias. Now, among the interstitial pneumonias, there are 6 major ones which are differentiated based on their chronic fibrosing profile, which are idiopathic pulmonary fibrosis and the idiopathic non-specific interstitial pneumonitis. Couple of smoking-related ones, which are often very subtle and respond to stopping steroids and a bit of stopping smoking and a bit of steroids, which are the respiratory bronchiolitis associated interstitial lung disease and the desquamative interstitial pneumonitis. And acute and subacute ones, which could be of interest to many of you, as they could mimic community-acquired pneumonia and can be quite challenging in managing, are the cryptogenic organizing pneumonia and the acute interstitial pneumonia. Couple of rare ones are the idiopathic pleuroparenchymal fibroelastosis, which could radiologically mimic TB with biapical, pleural, and parenchymal involvement, and the lymphocytic interstitial pneumonia. When clinico-radiologically plus or minus histopathology, they are not classifiable into one of these distinctively. They are put under a basket called unclassified idiopathic interstitial pneumonia, which can evolve over time into one of the well-established IIPs or even those with etiology. Then a huge basket are the granulomatous DPLDs, under which sarcoidosis and hypersensitivity pneumonitis come. And these are by far some of the highest prevalent ones in our country and likely to knock at your door quite frequently. Then there are a whole lot of known association ILDs where connective tissue disease take the bulk of it. Rheumatoid arthritis and scleroderma are the top ones. SLE, polymyositis, dermatomyositis can also contribute. And there are certain drugs which can cause ILD. The commonest among them are bleomycin, amiodarone, chronic use of nitrofurantoin, and so on. Occupational ILDs are also well known. Some rare miscellaneous ones are the lymphangioliomyomatosis and the Langerhans cell histiocytosis. These are all cystic lung disease. So if someone presents with pneumothorax and the CT shows cysts, then you need to consider one of these. Now, I spent quite some time on this slide because it's very important to grasp the spectrum of ILD and what they fall under if you have to recognize them when they present to you. There are some epidemiological data which has evolved over the last 10 years from India, which is from an ILD registry, which was predominantly in North India, PGI Chandigarh. Then there is a extrapolated prevalence study, and then an ongoing IPF registry, which involves 23 sites across India, where we are also part of. And this graph on the right bottom shows that between the two registries, sarcoidosis and hypersensitivity pneumonitis were the commonest. But we know from the ongoing registry, which has now collected more than 8,000 patients, 1/8 of them contributed from CMC, that connective tissue ILDs are probably the topmost. So the crude annual incidence, which is extrapolated from those studies, about 10 to 20 per 100,000 population ILD every year. Overall prevalence of 10 to 100. And then the national burden of each ILD is also extrapolated from this. So the focused areas we will be looking at it today are 3 F ending words, which are IPF, PPF, and IPAF. The profile of IPF is a elderly male, a smoker who has clubbing on general examination and bibasal Velcro crackles, and they have a physiological and radiological profile. In the lung function, one would have a low FVC, as seen here, with a restrictive ventilatory defect, reduced total lung capacity, and reduced diffusion for carbon monoxide. The diagnosis of IPF or any ILD, the gold standard is the interstitial lung disease multidisciplinary team discussion. So over the last decade, it has moved from histopathology to radiology to ILD. And then we need to look at the current agreed diagnostic algorithm, a bit on the role of HRCT. There's no time to look at BAL today, or the histopathology, which are also important components of this diagnosis. It's important to understand who are the members of the ILD MDT. So it has to have at least 2 pulmonologists and at least 1 with specialist ILD interest, because only then we will get the best out of the MDT. And a radiologist, again, someone who has special interest or focus on ILD. Now, these 2 are mandatory needed for the ILD MDT. There could be pathologists when there is a biopsy that's involved, a rheumatologist when there are connective tissue problems involved, and a whole lot of miscellaneous ones who could be there, but not necessarily. The role of MDT has been prospectively evaluated and found that it helps in confirming the diagnosis in a majority, and suggests in some and puts them under unclassified basket in some. And they come into play at different points in the diagnosis of IPF. It may not be just at initial presentation, but after a BAL is done, after a biopsy is done, after a cryobiopsy or surgical biopsy, at different points. So one patient may get discussed in an MDT more than once before a diagnosis is established. A bit focus on the HRCT for the understanding of everyone. So there are 3 distinct features which give us the smell of IPF on a HRCT, which is honeycombing, reticular abnormalities, and traction bronchiectasis. Now, traction is because of fibrosis, and that fibrosis, when it happens around bronchioles, causes traction of the bronchioles, and it causes ectasis. So it's not the classical bronchiectasis that we know of. Here, there is surrounding fibrosis that results in this entity. So it's defined as clustered, thick-walled, cystic spaces, usually stacks of 2 to 3 layers, but now even 1 layer is accepted, 3 to 10 mm in diameter, but can go up to 2.5. So if you look at the right picture and imagining that is what honeycombing is, well, that is what it is not. So what we see there is something called paraseptal emphysema, which doesn't have proper distinct walls, thick walls around it, and they are not multiple cysts which are by the side of each other. The HRCT classical appearance is given in this picture. The arrow in the E picture shows the honeycombing, and this is quite distinct from the previous picture, as you would recognize. And then there are areas of reticular abnormalities and traction bronchiectasis. So this is the radiological correlate of usual interstitial pneumonitis with this pathognomic of idiopathic pulmonary fibrosis. Now, this picture has interstitial, some reticular abnormalities and traction bronchiolitis, bronchiolectasis, but it does not have the classical honeycombing. So it will go under the probable UIP basket. Another scenario is where you have the reticular abnormalities, but you do not have traction bronchiectasis or honeycombing. It would be indeterminate for UIP. Or sometimes you could have honeycombing, traction bronchiectasis, and reticulopathies, but there are a lot of ground glassing, which tells you that there is alveolitis and acute inflammation going on. Again, in that situation, it would be indeterminate for UIP because those are not compatible with the idiopathic pulmonary fibrosis, where it is predominantly or only fibrosis. Then a CT like this, where you could have features of some fibrosis, some amount of air trapping, that as you can see there, and some amount of ground glass opacity, is classically called the triple density sign or head cheese appearance of hypersensitivity pneumonitis, and this would be an alternate diagnosis of usual interstitial pneumonia. Now, this is the evolved diagnostic algorithm, which is currently accepted for the diagnosis of IPF, where if you have a pattern of UIP or probable UIP in a patient with an appropriate clinical profile, elderly male, probably a smoker with bibasal crackle, that profile, then either of this could mean that it is IPF, and you do not need a BAL or a biopsy to prove this further. It goes into the MDT and comes out as IPF and is treated. But in case they are either indeterminate or alternate diagnosis, then it will go into the MDT and would be decided either for a BAL or a surgical lung biopsy or a cryobiopsy. And cryobiopsy may be preferred over surgical lung biopsy in today's date, where it is available, because it is much easier and the yield is comparable to surgical biopsy. Then it's put into this complex looking box where you have the histopathology and the biopsy, and it's matched to give the likelihood of IPF or alternate diagnosis. Now, we looked at our data of about over 6 months, 522 patients in an MDT, which we have every twice a week, and we found that 78% diagnosis changed after patients were discussed in an MDT, and the treatments were modulated in 60%, and that throws light on the importance of the MDT. IPF can have different trajectory going forward. Some can be rapid accelerators like here. Some are very slow progressors. Some have exacerbations which pull them really deep and they don't come out of it. Some are moderate progressors. But universally, almost all of them progress, and hence treatment initiation with antifibrotics, which is the only proven treatment, is important. This shows that the 5-year survival is around 30% with a mortality of 70%. And antifibrotics are the mainstay apart from rehab, vaccination, oxygen, lung transplantation, and palliative care, which are important pillars of this very difficult disease. Now, this slide is to show that the Kaplan-Meier curve shows that these are the impulses 1 and 2 trial, which proved that nintedanib is the appropriate for IPF. And if you look at it, even the nintedanib group had decline. But what it does over the placebos is that it slows the decline of progression or fall in FEC. So we cannot arrest the progression, but we can progression of fibrosis, but we can decline it. The next entity we will look at briefly is progressive pulmonary fibrosis. Now, this is a basket. It's not a diagnosis by itself. It is a basket for all non-IPF ILD. Everything else we saw in that classification. If they begin to progress with fibrosis, then they will come inside this basket. And this again, current standing goes by the 2022 update. And this, the blue shaded part of this classification tells us that what proportion of each of these non-IPF entities could actually progress to have fibrosis. And this is the classification, the definition which is currently accepted, which is they have worsening symptoms, physiology of decline of more than 5% absolute, and radiological feature which is consistent with progression. There's a lot of debate about what is the right physiological worsening, whether it's absolute or relative 5% or 10%. That is not possible to cover in this session, but that is something to be aware of. So this is a patient who had bibasal, reticular opacities, not much of traction or honeycombing. So it was non-IPF ILD, but over 6 months, it's progressed with some traction bronchiolectasis, worsening symptoms and physiology, and hence would classify as, suppose this was a CTD ILD, it would be CTD ILD with progressive pulmonary fibrosis. And the implication is this: those who have progressive pulmonary fibrosis do worse off in the long run as compared to non-PPF. And there are multiple trials which have proven that the conventional drugs for IPF like nintedanib and pirfenidone, the former more studied, are useful in the decline in lung function in non-IPF PPFs as well. This is again data from our institution, which has compared PPFs and non-PPFs among all non-IPFs and showed that there was more cough and dyspnea in those who have PPF or non-PPF. And among all ILDs, 20% had PPF, non-IPF ILDs. And among these, idiopathic interstitial pneumonia and hypersensitive pneumonitis had the maximum proportion of propensity to develop into progressive pulmonary fibrosis. And clubbing, Velcro, crackles, and IIP were the independent covariates of prediction of progression to IPF. And this is from data from the rest of the world, which shows that HP, RA-ILD, and SSC-ILD are the disease entities which are more likely to progress into PPF. There are some indications which have antifibrotics could be initiated upfront apart from IPF, and they are SSC-ILD and RA-ILD with UIP pattern. But there are certain finer details which have been to be looked into before one can start them on antifibrotics upfront without having to prove progression over time. I leave that. Just to break our monotony with a case scenario. There's a 39-year-old male who presented with episodic cough for many years, multiple joint pains for 3 months, small and large joint, and had progressive shortness of breath on exertion, and had this picture on the HRCT. As you can see, there are a lot of areas of ground glassing to consolidation areas with fibrosis and some traction bronchiolectasis that we can see. His ANA was also 1+. Because of a younger patient with this profile and ANA being positive, we did an extended CTD workup, which showed Rho 52 was positive, and the physiology was very much fitting into ILD. So here was a patient but he had no obvious connective tissue features clinically or on history. So he would fit into the third focus among our ILD topic today, which is called idiopathic pneumonia with autoimmune feature. So this is something that is a middle way between IIP and CTD in the spectrum of autoimmune tinge for the diagnosis. And we need to keep in mind that this is a research statement at this point in time. It is not accepted globally as a diagnostic entity. So it is IIP with some autoimmune feature, and sometimes rheumatologists call it UCTD when it's on the other end of the spectrum. So it needs presence of interstitial pneumonia. Usually UIP is not accepted, and alternate diagnosis excluded, and does not meet definite ACR criteria of a CTD. And then it should have one of 3 domains. I'll just quickly go through. This is the clinical domain. There is a serological domain with defined factors. So this is all from a 2015 IPAF research statement paper published by ATS CRS. And this is a morphological domain which has radiology, histopathology, and a multi-compartment involvement. Now, there are no population-based studies, but we do know that 25% of all systemic autoimmune diseases have IPAF, and 10 to 20% of all idiopathic interstitial pneumonias have IPAF, and overall 7 to 34% is the prevalent. The right bottom bar tells us that NSIP and OP patterns on CT are likely to have IPAF than unclassified or UIP or IPF pattern. It's important to note that 10 to 20% of them progress to CTD-ILD, and this proportion is likely to be larger because many of them are already immunosuppressed at the diagnosis of IPAF, and hence may not obviously show full-blown CTD over a period of time. So there is a spectrum. There is IIP on one end, then there is something called AI-ILD, IPAF, then there's UCTD-ILD, and then CTD-ILD. There are some criteria, but it's all not black and white. There's a lot of gray area in between evolving. So again, our data on from the INPF registry where we have contributed 930 patients. So we have IIP on one side and CTD-ILD on the other side. The IPAF is somewhere 40% in compared to the other two, and another 20% is UCTD. Actually, the UCTD and IPAF will fulfill criteria for IPAF by what I showed. There is more NSIP in IPAF and UCTD, which is comparable to CTD-ILD as compared to IIP, where there is more UIP pattern. Moving on to the second topic. I'll just quickly look at the time. Second topic is pulmonary hypertension. So I'll just jump into the current renewed definition. Earlier, mean pulmonary artery pressure of more than 25 was called pulmonary hypertension. That has been revised few years back to more than 20 millimeter of mercury. It can be divided into precapillary and postcapillary. In precapillary, the pulmonary arterial wedge pressure is normal or less than 15, which indicates it's not a left heart problem. And the pulmonary vascular resistance is more than 2 Wood unit. Isolated postcapillary would again have elevated MPAP, but the pulmonary artery wedge pressure will be more than 15, indicating that the left atrial pressure is high. And it will have a lower pulmonary vascular resistance, telling us that there is no precapillary component. Now, if there is both more wedge pressure and more vascular resistance, that's a combined post and precapillary pulmonary hypertension. Now, this is updated classification after the 7th World Symposium of Pulmonary Hypertension, which happened few months back. We have group 1, where we have pulmonary hypertension, where we have idiopathic, heritable, connective tissue disorders come here, and few other things like PVOD. The group 2 is those that contributed by left heart disease. Group 3 is what is contributed by the lung. Sleep diseases come here. Group 4 is that which is from the pulmonary vasculature obstruction. The classical among them is CTEPH, chronic thromboembolic pulmonary hypertension and other obstructions. And group 5 is those which have unclear or multiple mechanisms in causing pulmonary hypertension. We need to understand that the overall prevalence is only about 1%. And the bottom one helps us to understand that actually the left heart disease associated pulmonary hypertension is the commonest, followed by lung disease, and the other group 1, 3, 4, and 5 are quite rare. But if you see here, in the lung transplantation is applicable only for group 1. And the PH therapy is proven only for group 1 and group 4, which is the idiopathic and related group and the CTEPH group. For group 2, 3, and 5, trials are underway, but not very promising, except with some evolution in PH-ILD, which I'll come to later. So the focus areas for our pulmonary hypertension part of this talk is going to be pulmonary arterial hypertension, which is predominantly the group 1, and the CTEPH, which is the group 4, or what is related to thromboembolic disease. So this is kind of the approach. When a patient comes, we take a history and use non-invasive tools of ECG, NT-proBNP saturation, and then we move on to do echo and airway assessment. At any point, if there are alternate diagnoses, they go away. Their features of PAH or CTEF, we work them up expeditiously, and then they go through one of the other algorithms. The symptomatology is important. WHO functional class determines how they are treated. One is where there is no limitation. Two, with ordinary physical activity. Three is less than ordinary, and four at rest. This is the accepted echo approach to pulmonary hypertension, where you primarily look at the TR velocity. If there's more than 3.4, it is high probability. Less than 2.9 is low probability, and that determines who requires a right heart cath as you go through this pathway. In the 7th World Symposium, these are the additional features on echo, like TAPSE by SPAP ratio less than 0.5, and few other parameters have been included as additional features on echo to suggest PH. So this is the classical traffic light way of classifying pulmonary hypertension after it's diagnosed. So based on clinical, exercise physiology, echo, where done MRI, NT-proBNP, right heart hemodynamics, they are put into one of these. And this helps us to determine how aggressive we need to be with therapy. And this relates to mortality, as it's mentioned in the first row. Then once someone is initiated on treatment, there is a four strata monitoring of them, which is given here, where each of them have 1, 2, 3, and 4 points. As the points are assigned, it's divided by the total number of variables, and based on that value, further decisions on add-on therapy is made. Therapy is basically targeting these three pathways: the endothelin pathway, which has endothelin receptor antagonists, which prevent the vasoconstriction, which is propagated by endothelin pathway. Then we have the nitric oxide pathway, which is the guanyl cyclase pathway, which either there are guanyl cyclase agonist or PDE5 inhibitors, which work through the nitric oxide pathway, or the prostacyclin or the arachnoid acid pathway, where prostacyclins or prostacyclin receptor agonists are used to modulate the pulmonary pressures. These are the list of drugs and the doses which are appropriate among each of these categories. It requires slow titration because many of these have symptoms of vasodilation in the rest of the body, like flushing, jaw pain, and all that. So tolerability is a big issue, particularly when we combine two class. For example, we should never combine riociguat and sildenafil because they can cause precipitous hypotension. So in this, if we focus on just to show how the strata is helpful, the traffic light risk stratifies them into low or intermediate and high. And if they are lower, if they do not have cardiac comorbidities, and if they are low or intermediate, they get dual therapy. There's no role for monotherapy except when they have cardiac comorbidities. And if they are high, they require high risk, they require IV therapy upfront. Then after this, they are risk stratified by the 4-strata rule, and based on which category they fall into, add-on therapies are decided. A word on COPD, ILD, and there's something in between called combined pulmonary fibrosis and emphysema, where these patients have emphysema and COPD. And as you can see below, there is more pulmonary hypertension as we move towards the right. And there is research going on whether pulmonary hypertension drugs could be beneficial in these situations as well. So this is an NEJM article published in 2021. For the first time, inhaled prostacyclins were tried in ILD and found to have a difference in the 6-minute walk distance outcome. So there is a lot of upcoming role on inhaled prostanoids in pulmonary hypertension secondary to ILD. The reason being, when inhaled drugs are given, they focusly act only on ventilated airways and dilate only the vasculature related to the ventilator airways. And that is the reason why it is likely or being projected to be successful. CTEPH can present to you in three ways. One is acute PE, you do a CTPA and there is thromboembolic hypertension, or it follow-up of acute PE or when evaluation of pulmonary hypertension. And the treatment of choice is either it based on the location of where the thromboembolic hypertension is, thromboembolic embolism is there, the extent of involvement, the severity of PH and other comorbidities. And a MDT decides whether they go for a pulmonary endarterectomy or balloon pulmonary angioplasty or medical treatment, the drug of choice being riociguat. So this is pulmonary endarterectomy. For a long time, I did not understand this. So pulmonary artery is opened and then that clot which looks yellow in color is separated from the intima and a plane is made and it is dissected all along. On the right side, we have, that's similar like angioplasty where they go in with a balloon and dilate. So if there is proximal disease, then PA is the treatment of choice. If there is distal disease, then BPA is the choice. If there is microvasculopathy, then medical treatment. Of course, in many post-PEA and BPA also, medical therapy may need to be continued based on how much it responds. And this is, I mean, me and Vinay had the privilege of being in Royal Papworth in Cambridge, which is probably the #1 center for pulmonary endarterectomy. So this is the removed clots from a single patient where it is formulated back into the pulmonary tree on either side. So when these clots are removed, the pulmonary pressures really drop and they do really well. And ideally, pulmonary hypertension also needs to be managed by a MDT. We are nowhere there, but maybe in the future we'll get there. My last topic and 12 minutes left is lung transplantation. Here, we are still in initial phases, so this is not going to be an update. It's more on the basics than updates. So lung transplantation started in the 1980s, but the first transplant was done in India only in 2012. But as you can see, there is a huge rise in the number of transplants every year. And currently more than 5,000 transplants are being done across the globe. There are more of double lung transplants that are being done, as you can see by the purple graph, as compared to single lung transplant. So the indications are pulmonary fibrosis or ILD, airway diseases, predominantly COPD, bronchiectasis and cystic fibrosis. And in our country, post-tuberculous sequelae with very less residual lung and pulmonary vascular disease, predominantly the group 1 pulmonary hypertension are the indications. It's important to know that bilateral sequential single lung or double lung as it is called has a mean survival of only 6.5 years after the transplant. And there is a 15% mortality in the first year. Age is an independent factor. So if you go above 65 or 70 years, the mortality in the first year is about 50%. So there are certain very important principles from the referral or listing criteria point of view. They need to be on maximal medical therapy for that particular disease. And there should be a 50% mortality. The patient who's sitting in front of you, unlikely to be alive 2 years from now. And then a potential survival benefit based on his other comorbidities and all that. At least a 5-year survival should be reasonably good from other comorbidities. And he should be willing to accept the transplant. Early referral is ideal because if referral is too late, then they don't do well. It helps them to understand the concept of transplant because many people, after they hear the entire transplant, they decided this is not what I want to because you are getting away with one lung and disease and now with the new problem of immunosuppression, infection, and so on. But those who do well have really good benefit. So a lot of things can be related while they wait. So there is general fitness that's looked at, comorbidities, which I'm not going into, and disease-specific criteria. I'll focus on the disease-specific criteria. So for COPD, the listing criteria is a FEV1 of less than 20% with a DLCO of 20% and a board index of more than 7. That's very important. A board index of 5 to 6 is where you should consider referring a patient, and above 7 they would be listed. It is to be kept in mind that in severe COPD often we may not be able to give more life to the patient, but we can give excellent quality for the same life. as opposed to ILD, where it's a progressive disease. Bronchiectasis, where the FEV1 is less than 30% or more than one exacerbations. In pulmonary fibrosis, after maximal therapy, that is, they're on immunomodulation, antifibrotic as appropriate, and then there is a continued decline in lung function over 6 months, is when we need to consider. And PH for pulmonary hypertension, they need to be on triple therapy, including IV if they need to be referred. So putting it all together, ILD, any decline over 6 months, COPD board 7 to 10, bronchiectasis 25 to 30%, and the pulmonary hypertension on triple therapy. Now, the outcomes of a transplant assessment may be that they are too, okay, I'll skip that. So selection is important, timing is important. Can be bilateral, single, or heart lung. Heart lung is reserved for end stage pulmonary hypertension, but there is significant RV remodeling where it may not come back after even a lung transplant, or in Eisenmenger syndrome. Otherwise, only a lung transplant is preferred. Super urgent, all this is available in UK. Some states in India have. Tamil Nadu has only a normal priority, so we won't delve in that. So once they are listed, they have to be in and around Vellore and they should be ready to come. But the listing is based on their blood group, which has to match with the donor. Now, the donor can be either a brain dead donor or a donation after cardiac death. The second one is less explored in India. So we plan to start with the donation after brain death. We get about 8 to 12 in a year in Ranipet campus, and to start off with that and then go to out of campus hospital receiving, but they need to be HLA matched, and lung has a specific quality of being matched for the lung size as well. So based on the predicted TLC of the recipient who's waiting, the donor's predicted TLC has to match, only then it will be successful. So pre-op immunosuppression, antibiotics, then they go through ITU, then ICU, and then ward, immunosuppression, rehab. So this is a large incision across the chest and a sternotomy called the clamshell incision, probably one of the most morbid surgeries one can ever undergo in their life. And in the initial phase, there could be primary graft dysfunction, which comes like pulmonary edema. And then it's all managing the rejection, the acute cellular rejection, the antibody mediated rejection, the balance of infection, airway stenosis, Malaysia. So they required surveillance, bronchoscopic surveillance, TBLB to detect rejection early to get them going. So that's some of the bronchoscopic pictures and some stents that may be required to manage, but it's not required in all of them. The long-term complication, those who go through first year have relatively better outcome, and they have problem of lung allograft dysfunction, which is rejection over time, which is about 10% per year of those who survive. So in 10 years, everyone will have some kind of dysfunction, infection, malignancy of the skin and lung, because they need to be on lifelong steroids, mycophenolate, and tacrolimus. That causes malignancy, and renal failure. So those who live up to 10 years, about 20% of them will require a renal transplant as well. So lung allograft dysfunction can be acute, where they really don't come out of the initial PGD, or they may come out and they'll have a baseline allograft dysfunction, or the more described one is the chronic, where they present radiologically on follow-up with bronchiolitis obliterans on spirometry or radiologically with air trapping. Then they are managed with increased immunosuppression, inhalers. There is not much proven treatment for this, so it's a lot of supportive treatment, inhaler, and some like the azithromycin, montelukast, which we have learned from the hematology pulmonary GVHT cohort, is what we use. This is the organizational network in India. There is a national organization, there's a regional organization, there is a state organization, then we are all independent centers which are currently registered. So we just got our lung transplant license last month, and we are setting up the processes. The overall outcomes are improving with lung transplant, and the age at transplant, which started off at 40s, is currently age up to 64. So up to 70 is transplantable. And this is the Kaplan-Meier curve. The green is the adult, where the 5%, the 5-year, the mean survival is about 6.2 years. But if you survive the first year, this is after first year, then the mean survival is about 8.3 years. But more importantly, the quality of life improves. So I've seen patients who have come with wheelchair and oxygen. After that, when they come for review, they are running and coming because they have a normal lung function. So the quality of life tremendously improves after a successful lung transplant. So where are we in CMC? So we actually contemplated this in 2010 when experts from the world told that lung transplantation is not something for India because it's the only organ which is exposed to the atmosphere as well. So we left it. But again, in 2012, the first transplant happened in India. And then about 7 centers started doing. So we thought we should re-explore in 29, but then COVID struck. So we rejuvenated the plan in 2023. And me and Dr. Vinay from Cardiothoracic went for a STF. And we came back and we got the license. We planned to start this was a timeline submitted to the admin in 2023. First transplant in CMC was planned Jan 2025. We are not far behind. I think somewhere in the early part of 2025, we will be able to take off. And this is the pathway which you put. Patients will be referred to the lung transplant clinic, which is soon to start. They will be explained the process, and if they are willing, then they go through a screening MDT, which will have the pulmonologist, the surgeon, and some radiologists and adjuvant people. And if accepted for screening, they will be admitted for a screening purpose. And at the end of it, will be go through another MDT called the assessment MDT. At the end of it, if they are suitable, the patient will be told the pros and cons, and if they accept, then consenting will happen. And then they'll be categorized based on the blood group, HLA, and lung size. They'll be registered on Transplant after an appropriate advance, and then they need to be waiting for their appropriate donor to come. So in summary, I have covered 3 topics: ILD, pulmonary hypertension, and lung transplant. We are focused on IPF, which is a prototype of ILD. Currently, a UIP or a probable UIP in the appropriate scenario could very well mean IPF. ILD MDT is the gold standard. Progressive pulmonary fibrosis is an entity where 20% of non-IPF ILDs could have a progression in fibrosis. IPAF is a gray entity at the moment where it is between IIP and CTD, and the treatment is immunosuppression with steroids and mycophenolate. Combined pulmonary fibrosis emphysema, again, we just touched upon it, that's in between area. Under pulmonary hypertension, we look at the idiopathic or group 1, and we looked at where the drugs are the main treatment, and eventually they may need lung transplant. CTEF is the other main entity where based on the profile, they could either have a pulmonary endarterectomy, a balloon pulmonary angioplasty, or riociguat, which is the medical management. Lung transplantation, early referral is the key. The timing is very important, and success depends on so many factors. So we really depend on God's grace, because the first few successful ones is going to determine how our lung transplant program is going to go through. And we look up to you for appropriate referrals so that patients who could potentially afford and benefit it may have a good quality of life if they are able to go through it. So thank you very much for your attention.
Thank you, sir. We will now go on to questions for Dr. Barney.
There is an online question. Nitrofurantoin is commonly used long-term for UTI prophylaxis. Should be monitored for pulmonary fibrosis. Above what dose and duration?
So yeah, nitrofurantoin is one of the common urinary antiseptics which are continued long-term, and a proportion of them could develop lung fibrosis. So there is no recommendation to routinely screen them with lung functions, spirometry, or DLCO, and all that. I think it's very important to keep our eyes open to see if they are developing any symptoms, or ask for symptoms of cough and breathlessness. At any early point of symptomatology, we should evaluate, diagnose, and in which case stopping may at least prevent further progression. And based on still active inflammation, sometimes steroids may help in reversing what has happened as well.
The next question is regarding emerging therapies for ILD, recombinant human pentraxin 2, pamrevlumab, autotaxin inhibitor, senolytics. These are mentioned. Any use of this?
I don't have any idea. Well, at least we know that there are no established role in any of these. There are a lot of therapies which are being tried, because particularly IPF, where we don't have definite answer, there are a lot of treatments that are being tried, but we are yet to see the light of.
Many of them are animal studies which has potentially showed some benefit, but human trials with randomized controlled evidence is still lacking. Which drug is better for group 1 PAH, nintedanib or pirfenidone?
Well, I think you're mixing up ILD and PAH. If the question is for IPF or PPF, then nintedanib and pirfenidone are the two antifibrotics. Nintedanib has better evidence in the literature than pirfenidone, and also certain things like before a cardiac surgery with cardiovascular comorbidities, there are delayed wound healing with nintedanib. It can cause some increased cardiovascular problems in patients who are known to have cardiovascular disease. So in those situations, pirfenidone may be preferred, but otherwise nintedanib is the preferred drug. An additional point is that the pill burden, pirfenidone, we need to take about 12 tablets a day, actually, if you have to reach the maximum dose, whereas nintedanib only 1 BD. But both of them have significant GI side effects. Probably nintedanib slightly more. About 30% have diarrhea, a bit of weight loss. So sometimes when they don't tolerate one, we can switch to the other. But my preferable choice would be nintedanib for multiple reasons. Well, we have not started doing, so difficult for me to comment on although we have something in mind which I can't divulge. But the question is, in India, currently it ranges anywhere from 25 lakhs and 50 lakhs. So there are centers which do for 25 lakhs. There are centers who cost about 45 to 50 lakhs. So it's half a crore, but remember, this is the initial cost. Then they need to be on lifelong immunosuppression, have money to manage complications and all that. So we are working out something which we'll be able to tell our patients when we counsel. So our hope is somewhere around 20 lakhs, so that we are, economically okay and acceptable. But we are still to work out the yearly cost lifelong, because for a patient that is important. It's not that do a transplant and then we forget about it. We need to know if the patient is able to sustain it over time.
One more is the role of pirfenidone for PAH-related lung fibrosis.
Well, the antifibrotics, they work by mechanisms in delaying fibrosis. So the numbers and studies are all in interstitial lung disease, but there are other diseases which could cause fibrosis. We do not know the answer because there is no strong evidence. For example, people used a lot of antifibrotics post-COVID, but then we saw those who do not have used antifibrotics also resolved, because that is the spontaneous nature of the disease. So paraquat lung injury is a very focal area, and there is no established evidence. And just because you give pirfenidone and patient improves, you cannot say that it's because of that. So I would say there is no established role.
Very interesting talk, Dr. Barney. I have a question for you, because you initially mentioned that somebody said lung transplant is not for India. So was it due to the infections or due to the air pollution, which is currently a very hot topic?
It wasn't hot. Air pollution wasn't hot like 14 years back. So it was predominantly from infection. Looking at India as the number of airborne infection, TB, and the immunosuppression. And we need to remember that lung is the only organ where the transplanted organ and the infected organ is going to be the same in most situations. That makes it very difficult. So I think it's from the infection perspective, Dr. Atul Mehta made that statement that lung transplant is not for India.
Thank you, Dr. Barney. That was an excellent talk. You covered extensive topics and gave us traffic light guidelines, which are, I think, engraved in our brains. Thank you for that.
Thank you.